Aloha, everyone. Happy Tuesday. Welcome to Behavior Health Echo. Today, we are happy to have Mr. Andrew Kurtz. He is a clinical specialist with UCLA Integrated Substance Abuse Programs and co-director of their Integrated Substance Abuse Programs Pacific Mental Health Awareness Training Project. And today, he will share with us on reducing stigma with cultural humility. So without further ado, we will hand it over to Andrew. Thank you for being here.
Thank you so much for having me. It's so nice to see you all and to see some familiar names, familiar faces. It's been a little while since I've done one of these echo sessions, so I'm looking forward to our discussions. I'm going to share my slides and we will get right into what we're talking about today. So we're going to spend a little bit of time talking about recognizing the impact of stigma and then thinking about how to address these issues that may come up, how these challenges may come up in treatment, and consider how this might impact our outcomes, but more specifically, our ability to connect with and engage with individuals in care. And think about this depending on your role, depending on your organization, where you're working and how you're working in that space. As Summer mentioned, we've been doing work with Hawaii for a while, and we value these partnerships immensely. And one of the opportunities that we've had over the last couple of years is to introduce a new project focused on mental health awareness and to deliver those trainings not only on Oahu is where we did it in person, then we had a remote session. We've also been fortunate enough to deliver those trainings to some of our other Pacific partners on Palau, Guam, and Saipan. And this conversation about stigma is really interesting in different locations because what I may consider stigmatizing isn't necessarily the same exact consideration in different regions, right? So when we talk about this idea of cultural humility, it also embeds within it a conversation about cultural norms, about cultural standards, about how we understand substance use and mental health disorders, and how we have conversations about those. So I'll try to integrate some of that as we're going through today, but I really want us to focus not just on this broad conceptualization of stigma, not just this broad understanding of how stigma affects treatment, but really to consider what this looks like in our communities, what this looks like in our treatment facilities, and how there might be some unique differences between communities, between different regions about how we talk about substance use, about how we talk about treatment, and how we think about stigma. One of the interesting kind of anecdotal patterns that I'm noticing more and more as I'm talking with providers is that some of the stigma that I've seen around mental health discussions doesn't necessarily exist in the same way for younger individuals. So if we're talking about some of those cultural shifts, one of the things that we're seeing in treatment, one of the experiences that I'm hearing from other providers and supervisors is that when it comes to talking with younger individuals, they seem much more open to talking about mental health challenges. That doesn't necessarily seem to be the case with substance use necessarily, but we are, even within that, witnessing some interesting trends in terms of use that may translate into how we talk about this. This is a slide that we include in front of all of our trainings, and I think that it's particularly relevant for this topic. And so I'm going to spend a little bit of time on this, just setting the stage for what we're going to be discussing. One of the ways to begin to combat stigma is to draw attention to it. And because of that understanding that that's how we start to combat stigma, we've included this in all of our trainings. It goes beyond just including it. Yes, I want to make note of it. Yes, I want to highlight the importance of the language that we use. But I want to think about how I make this useful, right? How do I translate this from just a slide to something that I can integrate into whatever kind of practice I might be engaged in. And so this slide really highlights and primes us to think about, how do we use language that puts people first? Because we recognize that the language that we use in treatment, in how we talk about treatment, in how we talk about our clients, or how we talk with one another, all of that can either further stigmatization about substance use treatment or mental illness, or we can use language and we can talk about this work that we're doing in a way that holds the perspective that the hope of recovery is possible for everyone. And we do this through affirming, respectful, and culturally informed language that promotes evidence-based care. So we're combining this idea of the science behind what we know works with how do we connect with an individual? How do we meet that person where they are? And you hear that term a lot, and sometimes it's literally meeting somebody where they are. Sometimes it's considering, how do I best connect with this person in this moment based on what they need, based on how they're coming in to see me, and how do I go through this process without forgetting the person at the core of this? And I know sometimes that's easier said than done, that this work can be difficult. It can be stressful. We talk a lot about burnout and the impacts of the pace of the work. That's all really important to consider, right? Because that's part of the work. I always want to consider within that, however, how do I not lose sight of, yes, this is another intake or another assessment I have to complete. Yes, I have to complete my documentation and my billing and my charting. All that is really important, certainly. How do I not lose sight of the person at the center of that? And some of that is related to cultural humility. This idea that to engage in a process of cultural humility requires choice and it requires action. It's not just the recognition, but it's the recognition and the choice to do something with that knowledge. How do we choose to enhance cultural proficiency? What are some of the ways that we can begin to understand the cultural nuances of a particular group that might be coming into treatment or an individual? How do we continue to add to our knowledge base? How do we seek out additional training opportunities, additional knowledge opportunities? And then a slightly different process, how do we check in with ourselves? How do we look at our own personal and professional biases and assumptions and the ways in which those might impact or affect the care that we're providing? And that's a little bit trickier because there isn't necessarily one right way to do that, but we may not also incorporate that in our practices regularly. It's highly dependent upon the kind of feedback and support that you might get from others within your organization or within your profession. Supervision and support are critical in that. So if we're trying to understand our own assumptions and biases, if we're trying to engage in a consistent practice assessment where we're reflecting on our processes, having quality, regular supervision and support is critical. We want to choose to take professional and culturally competent actions that promote health and goal attainment for all individuals. So part of that is messaging. Part of that is what we do with an individual when they come into our practice or our offices. And then we want to acknowledge, we want to incorporate the acknowledgement and investigation of where we might be delivering less culturally competent practices. How do we recognize some of the limitations of evidence-based practices as we understand them? This is a conversation that we have a lot, again, as we're working with different communities across the Pacific. When we think about culturally competent or culturally informed practices, oftentimes what we have is we have a foundation of interventions or skills that are highly based on a very European, westernized perspective on how to deliver healthcare. And oftentimes the research that goes into creating the evidence base for this particular approach is focused on a very small segment of the population that doesn't necessarily incorporate the experiences and the needs of different communities that we might be working in. So we want to recognize the way in which this aspect of culture shouldn't be something that we kind of shoehorn or add into what we're doing, but rather it should be a foundation from which we recognize the benefits and the potential drawbacks of utilizing the skills that are available to us. We have the willingness and the fortitude to engage in an ongoing process. And I think by being here today, you are taking the first step in doing that. So keep this in mind as we're moving forward. This is to a slight degree spoiling the message for the rest of the session, because I'm giving you kind of the summary of it at the beginning. But I want us to consider this as we think about how to do this for ourselves. How do we think about these aspects applied to our practice, to our communities, to the individuals that we're working with?
I just want to comment that it's an interesting picture because the hands get lighter as you go up the huddle on this picture, and usually we mix it up more, you know? Anyway.
Yeah, there's certainly a gradient to the picture as well. And I think that it's a good recognition, because one of the things that we're trying to do, even just as much as we do these kinds of trainings, doing an audit of kind of the imagery that we have is critical, because stock imagery, which we have access to and which we incorporate, doesn't necessarily reflect at all times the message that we're trying to convey. It doesn't necessarily reflect who we're speaking with or the clients that we're talking about. And so even within that, you see opportunities to continue to check in. And part of cultural humility is recognizing that, yeah, maybe I might need to shift that a little bit. And I might need to recognize where there's an opportunity to manage things that I typically don't consider or maybe even just take for granted. Another good example of that we'll talk about in just a little bit is our department name at UCLA, which I will come back to. So consider that this is an ongoing process, and sometimes we are focused on changing what we are able to, and then engaging in longer process conversations around changing systems. Good observation, Dr. Whitty. Thank you for that. Yeah. We're going to cover some terms and definitions, and then we'll look at specific examples of difficult situations that may come up or difficult conversations. And then we'll incorporate in this recommendations that you all might be able to consider. But hopefully by the end of this, we'll be able to incorporate some of these components into a case conversation or some practical application that might be relevant for your work. Some examples to start with that might be situations where stigma may come up or that might create a difficult conversation. When you're talking about homelessness or poverty, socioeconomic status, or you're talking about whether an individual has access to housing or not, it's a situation where there may be some stigma in the conversation. There may be biases that may come up in our conversation as a provider or in consultation with other providers. When you're talking about medical issues or disabilities, when you're talking about mental health, personality issues in particular, seems to come with a lot of stigma, a lot of bias, particularly amongst providers. Makes sense because that is one of the more difficult and draining cluster of symptoms to try to manage in treatment. And so it would make sense that individuals are more frustrated. How do we manage that piece? Not by minimizing the difficulty of the work, but by recognizing the way in which if we allow those frustrations to seep into the work that we're doing, we might become less effective. When we think about some of the treatment recommendations for things like opioid use disorder or alcohol use disorder treatment, or even just broadly how we talk about substance use disorders in our communities, in our settings. When you think about an individual's identity related to gender or sexual orientation, if an individual is part of the LGBTQ+ community. When we think about social or religious preferences and the way that informs or potentially defines our medical conceptualizations, we know historically substance use disorders were viewed as a moral failing, and that is still highly integrated into our practices even today. How do we even just work with patients who are culturally different from ourselves? How do we ensure that we're recognizing that there may be some benefit to adopting a stance of cultural humility in every scenario. And then how do we best ensure that we are connecting with an individual in a way that doesn't promote or reinforce either systemic barriers or interpersonal barriers related to potentially some of the cultural differences or biases that an individual may hold. An opportunity to reflect on a scenario before we get into a case example. I want you to imagine that you're visiting with your sister. She recently had a visit to the doctor for numbness and tingling in her feet. She says that her doctor told her in this visit that she has diabetes and that she's stupid for letting her diet get so out of control. The doctor's recommendation is that she see a dietitian and gain some self-control. Once she does that, he'll consider treating her diabetes directly with medicine. The doctor tells her that treatment with insulin will do her no good until she's really ready, and he'll know that that's true when she loses some weight. The doctor tells her to come back when she really wants to change. No follow-up appointment is scheduled. So for those of you who would like to share in the chat, you're also welcome to unmute yourself if you would like. What is your reaction to this scenario? Imagine that you're talking with your sister. What's your reaction to this scenario?
I know somebody's got a reaction. Horror.
Horror is a very strong reaction. Good, thank you, Dr. Cohn. Appreciate that.
Absurd.
It's absurd.
Get a new MD.
Karen just wants to fire the doctor entirely, which is, I think, in this situation, not unreasonable.
No, that's a good thing to do. Yeah.
Yeah.
Anybody else?
Good. Other reactions. And if you're not thinking about reactions, potentially, what do you do in this situation? So we got some of the reactions: horror, it's absurd. Maybe you get a new physician entirely, you fire that doctor. What do you do in this situation?
So shut down, don't come back. It's non-therapeutic. It's blaming the victim. All true. Oof.
Good. So I think the reaction is clear, right? The reaction is one in which we recognize that. I even think that this might be a little bit generous, that this is non-therapeutic. I think that's true. I think it goes a little bit beyond that too, where it's certainly non-therapeutic at best. And more likely there's an absurdity to this, because there's such a disconnect between what we would expect to happen and what this individual, our sister, is actually experiencing. We recognize that part of that is the absurdity of the MD judged our sister without really finding a way to help. Oh, go ahead, Dr. Whitty.
Oh, no, I was just going to say that's exactly what Taryn said. The MD judged her without trying to figure out how best to help her. And then we have a real life setting. Christina says, reminds me of a case where the clinician would not provide mental health services until the client stopped smoking cannabis. Not helpful.
A great example, right? And one of the reasons that we provide this scenario is because I think most of us would understand that going to the doctor and expecting some help, some support, and not getting that, and to be judged and shamed, it's absurd, and it's horrific, and it's impactful in a really negative way. And yet, if we think about substance use treatment, there is still a segment of the treatment population that does treatment in this way, that believes that it is your fault, and I'm going to treat you as such, which is incredibly harmful, right? It's this idea that certainly it's non-therapeutic, but this example of shutting down and not coming back has a ripple effect. So yes, there's the immediate impact that I feel terrible that somebody would have to go through this. It's shaming, it's embarrassing. But then we think about what happens next. maybe your sister goes back to this individual. I would imagine that if your sister were to go back, that probably wouldn't be a really good relationship. And more likely what's going to happen is your sister's not going to go back to this individual. And so now your sister has discontinued treatment for a medical condition from which she could have benefited from some support. So she's no longer seeing anybody. She's discontinued treatment. And I don't know about you all, but I find that, like, I think I have decent health insurance. I think I belong to a pretty good health system. I think I'm reasonably capable, and it is a nightmare to try to continue care. So the fact that an individual has discontinued care means they now have to go through a process of re-engaging in care. And if they have to go through a really complicated process, the frustration of that may mean maybe this person is just going to say, you know what, forget it. I don't want to go through that again. And if they are to be connected with someone, not only are they going to be connected with that individual, but now they're probably less likely to trust that person. They're less likely to talk openly with that individual. They're less likely to want to share information that's going to elicit this kind of reaction. So as a provider, you may not be getting the information that you feel like you might need to fully understand this individual's scenario. Moreover, as a provider, you're inheriting whatever stigma occurred previously. So it's not just don't be a bad provider, right? Certainly that's the message here. But I think we also have to take that one step further and recognize that what you see in the room, what the individual is exhibiting, may not be entirely based on your interaction. It may be part of what you're inheriting from the culmination of this person's negative experiences leading up to this point. And that may not be just in formal treatment. That might be what they're being told in their community, what they're being told by their friends, what they see in media. And that's not going to come out right away in a discussion. Somebody's not going to come in and say, well, here's how I've been treated and here's how I see this. That's an intensely personal experience that somebody might have that they're certainly not going to share with you if they don't trust you. So much of what we're talking about here isn't just understanding the impact of stigma or recognizing what stigma is. It's also this understanding of the importance of engagement in a relationship that, again, I mentioned this previously, we can't lose the person. We also can't lose our empathy for what that individual is experiencing or has experienced. I don't want to inadvertently reinforce or induce a barrier in what's already really complicated in terms of barriers to get people into care. Go ahead, Dr. May.
Oh, Ann Leek, who I haven't seen for a while. Hi, Ann. Said she's had 2 homeless patients whose surgeons required 2 negative drug screens before they would operate. And in one case, the woman died of metastatic breast cancer at age 32. So this is no joke. This is happening all the time. And I wonder if buprenorphine would have been considered a positive drug screen even.
It's really unfortunate, right? Because I can understand some of the rationale for wanting to ensure that somebody isn't using substances before initiating a major surgery, certainly, right? There's reasons for that. But what's the process leading up to that? And because we do have resources, as you mentioned, we do have resources to support individuals to get to that place. And if we're not actively doing that, then these are the kinds of outcomes that can occur, unfortunately. I appreciate you sharing those stories with us, and it's unfortunate that was the outcome. You all know this. We never want to be in situations where we think, could I have done more? And we always feel like we could have done more, but even just thinking about what kind of support can I provide to try to connect with this individual, to try to make sure that they understand the importance of our interaction, of the benefit of this support. I want to make sure that I'm conveying that from the moment the person steps in my office, and potentially even before that to a degree. All of what we're saying here is that words and attitudes have power, right? What you do, how you say it, all of that has a great deal of power. People place a great deal of value on health. It is generally accepted that people should not be discriminated against for their beliefs. And yet people continue to experience bias in a healthcare-related setting based on things like their health status, their religion, their race, ethnicity, their sexual orientation, their gender, their class, their ability, and many other characteristics. And this is what we refer to as stigma, which by definition is a stain or a reproach on one's character. It's an identifying mark. So you think about when you read the Scarlet Letter in elementary school or whenever that was, that is an allegory for stigma. It is a visual representation of the stigma that might be held socially or within a community. We also recognize that no other medical condition is shrouded in stigma like substance use disorders. Now, that isn't to say that other neuropsychiatric conditions or other medical conditions aren't stigmatized, but we actually know from a research standpoint that the experience and impact of stigma related to substance use disorders is greater than that of medical conditions and other neuropsychiatric conditions. One of those studies, so an example of this, one of those studies looked at how an individual is referred to. You have the exact same information about a person, and a group is divided into two. One group is told the individual is a substance abuser. The other group is told that the person has a substance use disorder. For the group that had the substance abuser, the participants felt that this individual was less likely to benefit from treatment, which is not a strong starting point, right? If you believe that this person won't benefit from treatment, what does that mean in terms of how you might engage with that individual? That group believed that this individual was more likely to benefit from punishment. So not only is this person less likely to benefit from treatment, but the course of action that they would benefit from is to punish them. They were viewed as being more socially threatening. They were more likely to be blamed for their substance-related difficulties and less likely to be viewed as having an innate dysfunction over which they had no control, which reflects our current understanding of a substance use disorder. And they were also viewed to be more able to control their substance use without help. And you can see the way in which this would easily translate into a moralizing standpoint. You're not doing what you're supposed to. You need to do better. You need to try harder. It's all on you, rather than recognizing the course of this dysfunction and the way in which that might remove some of that ability to control, that aspect of control. And what good does blaming this individual or threatening this individual do in this situation? We also recognize the complexity of intersectionality. This idea that there is an overlapping system of multiple social identities that interact with the micro level interpersonal experiences and the larger macro level systems of privilege and oppression related to racism, sexism, gender identity, social or sexual orientation, and classism that happen at those macro levels. Intersectionality can create a complex picture of overlapping identities. And what we often miss is the nuance in treatment of this overlapping identity. You saw before this kind of got really pinpointed. This is a really beautiful, kind of almost like stained glass mosaic or overlapping image of these different identities. What we often see in treatment is just one small portion of that, especially early on. If we don't take the opportunity to understand the different components of a person's identity and the way that that's an experience, the way that individual experiences the intersectionality of their identities. Right, and I see in the chat that, yes, substance use disorders is not an innate disorder, right? So there may be some vulnerabilities, predispositions, but this isn't certainly something that is innate or characteristic of a particular person. I love that distinction, because if we say that this is innate, it says that this is something specific to this particular individual, like an ability, right? Where we're tying it to their identity rather than viewing it as a medical condition. When an individual experiences stigma, internalized substance use stigma is associated with worse outcomes in treatment, including worse mental health and less engagement in care. Internalized substance use stigma and internalized HIV stigma combined have greater associations with depression than either alone. So when we think about this overlapping of identity, you're seeing a stacking effect of the stigmatization, of the impact of stigma based on those different overlapping components of the person's identity. Therefore, what we recognize is it's not enough to be culturally competent, right? Because of the complexity of an individual's identity and their experiences, we'll never be fully competent in any one person's cultural identity. Rather, what we should be looking at is understanding the complexity of culture, the dynamics of the interaction between thoughts, communications, language, practices, beliefs, values, customs, courtesies, rituals, everything that goes into an individual's experience, how they define themselves and the world around them. We should be taking an opportunity to integrate a conversation about that in our treatment planning, in our assessing, because the dynamics of culture are complex and they are not set in stone. So just because we recognize this at the start of treatment does not necessarily mean it will still be relevant or significant when we're talking about, how do we support you to make sure that we get you to this place where you're able to get those surgeries that are going to be critically important? How do we get there? And how does that fit within your understanding of yourself and your world? Cultural humility instead of cultural competence gives us an opportunity to think about this as an ongoing professional and personal development process where we're continually self-examining, looking at our own biases and refining our awareness, our knowledge, our behaviors, our attitudes, and the way in which this interacts with power, privilege, and social contexts. We want to engage in self-reflection and self-critique, right? Thinking about, is this clip art that I've used, does it have a gradient to it that might indicate or reflect some of these existing systemic imbalances? And can I potentially find something that better reflects the message that we're trying to convey? We have in our name, it's been said multiple times, the Integrated Substance Abuse Programs, UCLA ISAP. That is something that we are actively trying to change, and it takes time. And so we continue to promote this idea of substance abuse when we know, one, it's not clinically relevant to use that term, and two, it could further stigmatization. Look at something like SAMHSA, the Substance Abuse and Mental Health Services Administration at the federal level. It's hard to get names changed. It's hard to change systems, even though we recognize the importance of that.
They are trying to change, though. We heard.
Yes, they are. And yeah, I think that there was a press release, wasn't there?
I don't know. The deputy director, who is in recovery for many years, he talked at our conference last week, and he said they are trying to change the darn name.
And even then, you can hear the frustration that we're trying as best as we can, and it takes time. And so part of this effort is to recognize that our existing systems, whether that's a formal professional system or you're talking about patterns, processes, rituals, activities that exist at the community level, it's hard to change those. It's hard to shift those. And so we have to consider the way in which we can check in about this and be diligent about how we come up with plans to address stigma. Cultural humility requires us to some degree, relinquish the role of expert to the individual that we're working with, become a student of the patient, and see the patient's potential to be a capable and full partner in that therapeutic alliance, to allow them to share their experience and share their story, and to redress the imbalance of power that is inherent in any treating provider and patient relationship. Now, I think it's also important to consider that each of our patients or each of our clients are not a monolith that represents a particular cultural identity. That is their identity for themselves. And while we might learn about the individual, it is not their responsibility to teach us about their culture. It is their responsibility to engage in treatment, certainly as fully as possible, but we have to be there to support that. And so if I'm using that experience as a starting point, it is incumbent upon me to then further my own professional education in whatever way I can to better engage with individuals who are part of a particular community or group. We have to develop these mutually beneficial. It's not paternalistic. I'm not meeting with this person and talking about culture solely for my benefit. There has to be some benefit to that person in care. And so in practice, cultural humility means bridging perspectives between ourselves and the people with whom we work, remaining open to learning, open to these conversations. Just because you worked with someone with one blank doesn't mean the next blank will be anything like them. And you can fill in that blank with any component of identity, any aspect of a person's functioning that you would like to. How do we begin to counteract this? Discrimination occurs when someone holds a negative opinion or attitude towards others. Sometimes this isn't known or it isn't obvious. We want to provide education and get to know somebody who might be a marginalized member of that group, or potentially get to know that group, get to know individuals in that group, not just one person. Education is key. Consultation is key. Become aware of some of the experiences of stigma that exist in your communities. Disclose information selectively to counteract stigmatization when it's useful. Avoid labeling your clients, right? So don't refer to somebody as a label, treat them as a person. Receive training to begin to become aware of unconscious biases and how those are ingrained systemically in our work, in our practice, in our lives. Use person-first language. Again, keep the person at the center of that and create an atmosphere that is supportive with zero tolerance for discrimination. Call it out when it occurs and provide supportive reflection and guidance to realign values that are consistent with our practice. Acknowledge clients' significant others and encourage involvement at the community level. Use active listening. Use those good motivational interviewing skills. Reflect what the client is giving to you. Be a mirror rather than interjecting your thoughts, your values, your beliefs. Lend your clinical and professional perspective, certainly, but recognize the delineation between that and where you might be adding your own individual perspective. Reserve judgment by remaining open and avoid drawing stereotypical conclusions. Another way that we can begin to counteract stigma is by thinking about what language we use. And there is a publication called the Addictionary that can assist with this at the substance use level. So thinking about moving away from terms like clean or dirty, which have a value judgment embedded in them, rather a person in recovery or a person not yet in recovery. If you're talking about labs or test results, a positive urinalysis, a negative urinalysis, rather than a clean or dirty test. All of this, while it may seem simple, goes a long way in breaking this cycle of stigmatization. So a few additional tips, and then we'll get into some examples of this, which I'm sure there are many. Conduct a language audit in your organization. Look at what language you use in materials and how you talk with individuals, and then consider how you might be able to replace some of that language to be more inclusive. Reflect on the types of information that you choose to disseminate. What are you choosing to disseminate and what language do you use to do that? And then ensure that you're doing so responsibly in a way that reflects on this idea of hope and belief in recovery. Are you unintentionally editorializing or adding commentary that could bias a message or further stigmatization within the information that you are promoting? Every time you develop a prevention message or method, consider it as an opportunity to dispel myths and convey respect for the individuals that you're focused on. Maximize connection, worth, and community. It goes a long way in reducing the barriers related to substance use treatment. And then the last one here, train staff on issues related to substance use and mental health stigma, or even just understanding substance use disorders so that they can be better prepared to promote this idea of hope and recovery as they're talking about substance use disorders. Final reminders, SUD is more stigmatized compared to any other psychiatric disorder. Keep in mind your messaging. If we convey that there are treatment options that are effective, that are accessible, it helps immensely. SUD education, understanding why we don't say substance abuse, understanding why we don't use that term any longer, goes a long way in reducing stigmatizing biases. People are seen as more to blame for their substance use disorders compared to any other psychiatric disorder, and those who hold stigmatizing beliefs about SUD themselves are less likely to seek treatment and less likely to engage in care. So think about our messaging, think about how we can promote this idea and carry that forward in all of the conversations that you have, particularly those that you're having with clients. And remember, always keep that person first and not lose sight of the individual at the core of what we're doing. I'm looking forward to our discussion. Please reach out if you want to send me an email at any point with additional ideas, considerations, feedback. I'm always open to that. So please feel free to email me at any time. I appreciate all of you being here and look forward to our discussion for the next few minutes.
That was really nice. I've known all this intellectually, but I think I feel it more now. You know, let's see, we got some comments here. And Renata said, insurance paperwork needs revised. Renata, email me what you know of specifically needs revised, because I'm working with the insurers to simplify prior auth, and this hopefully would be something easy, you know. Oh, for language there. Stigmatism is on both sides of the desk. It's true.
So true. I love that Renata is already thinking about that language audit for the existing materials. That's great. That's wonderful.
Because that's kind of a low-hanging fruit. I'm excited about that.
Great place to start. Yeah, absolutely.
Yeah, I mean, the insurance companies are changing everything every month, so they can change their paperwork. But yeah, I guess, I mean, I've heard what you've said before, and I've heard, you know, the comparison to a diabetic, you know, but I don't know, you just kind of gave me hope.
And you know, if that's great if that's the case, because that's what we're trying to do. You know, I think that there's so much in this work that is, like, we talk a lot about burnout, we talk a lot about the frustration. There's so much that is impactful in that way. It's hard to hold on to that hope sometimes. And if we have a hard time with that, imagine what that must be like for our clients. And that, I think that hope is critically important in trying to achieve the outcomes that we're looking for.
Other comments or questions? How are we going to make changes in Hawaii?
Could I say something? This is Ann Leek. Well, I retired a year ago, so I'm an outsider everywhere. I don't have any inside pull anywhere. And I really do want to change that policy of the surgical department at this large quaternary care hospital in Honolulu that really doesn't really seem to want to have homeless people to take care of them. And so I've consulted the Hawaii Disabilities Rights Center's executive director, who is a lawyer, and he said he would look nationally, but he couldn't really find any cases of policies and procedures at healthcare organizations that discriminate against people with substance use disorders. And so I'm kind of looking for a strategy for this, because the lawyer said, oh, come on, you must know some nurses at that place, and you can get their policy and procedure regarding drug screening for pre-op. So we have a whole center where the pre-op evaluations are done. And this is where a nurse practitioner did say to me, well, it's really up to the individual surgeon. I mean, if they are happy with one negative screen a week before the surgery and then one negative screen the day of the surgery, that's their prerogative. But why should it be up to someone's prerogative? And, you know, trying to do a literature review on this, I mean, all I got was anesthesiologists saying, oh, meth on board, no problem, this is what you do. And it gave you a cookbook for how to monitor somebody under anesthesia who has methamphetamine on board. So, yeah, I mean, there's a formal route, which I could lodge a complaint and ask for a response. But when I've complained to this institution before, I've never gotten a response. So I don't know, I'm just sort of looking for ideas. Maybe you have some ideas, Andrew, about whether to storm the front door, or in Hawaii, we tend to work more quietly behind the scenes. But I'm so upset by all of this that, you know, and I did consult a malpractice lawyer, and he said, well, unless you can show that the delay was at least 12 months, you can't really prove that that delay was connected to her death. And then we stopped there. But changing policies, procedures in institutions, I'd be all for doing that.
So Renata had her hand up for a second, but I just want to say, Joseph Kona Maui says, thank you for acting, Anne.
And I haven't acted yet. I've just been steaming.
Some refuse to see the issue. Yeah, I mean, there is, if someone's on meth, maybe, you know, the surgeon can say, oh, I just don't want to deal with that. So then just eliminate meth, you know, just do a drug screen for meth. But anyway, so your question was, what can we do?
I think at the policy level, there is a lot of room to grow, and I will say that as diplomatically, I think, as possible. But and I think that you're knocking on that door to a degree, which is really encouraging, because I know that not everybody who's doing this work has the motivation, the skill, the insight, or even the inroads to potentially scheme to affect that level. But that's part of what does need to happen, is that there needs to be some of those broader systemic or policy level changes. And it's one area where the evidence can be helpful, but at a policy or even a political level, locally or nationally, it is possible to affect changes without a substantial, significant evidence base. And so that might be one direction to go. If you're talking about kind of the practice components, that's a different story. I mean, maybe the insurance companies, maybe establishing a work group, a group where you could leverage some willingness or existing motivation among providers to promote this message or promote this idea, could be a different way of affecting it at that more immediate level. But beyond that, I'd be interested to see what others are considering. A lot of that is certainly the policy level. The modifications are always slower going, and it does take getting the right buy-in at the right time with the right person.
I would agree with that. Renata, do you want to? Renata says it comes to outcomes of surgery. So I would be interested to know which medications impact the outcomes of surgery. And perhaps instead of just saying no to the surgery, we put them on buprenorphine or something and say, hey, try this while we do your surgery and let's see. But, you know, the surgeons don't want to waste their time doing that. Maybe it's a statewide grant. Did you want to add anything, Renata?
Yeah, well, you know, I worked as a surgical nurse in pediatrics for almost 5 years, and it's a little bit more complicated than that. I think there's so many different aspects to it where, like, it's not only the medication that they're on, or it's like all of the consequences that could happen. A DVT could happen, or you know, you have to, you know, people who are not substance use users or have that history are at risk for clots or so many different things, and they have to stop their blood pressure medications or their birth control or their warfarin or whatever it is that they're on. Sometimes, you know, 7 days prior. And if you have somebody that's not going to follow that, you have no idea what you're getting during the surgery. You know, if they just, you know, used cocaine the day before, or even smoked and all of that, it does affect it. And I think that's one of the reasons. And then the other reason is surgeons, you know, have a tight schedule. And if somebody is not showing responsibility, are they even going to show up for the surgery? There's a lot of preparation that goes into that. And I think all of those things, even though I agree we should not be discounting people's need for surgery, regardless of what their choices are in life, I do think that there is, for people who are waiting for a transplant of some sort, I know that they recently opened it up to people who have a history of choices that were not previously accepted before. But, if you're trying to decide between somebody who gets a liver who is, 95 and has all these other complications versus somebody who might live, 50 years with the liver, kidney, or whatever organ it is, there are choices that need to be made. And so I think that, this is such a complicated thing. I didn't even want to say anything about it because I cannot do it justice in in an hour, let alone just 5 seconds to respond. But the thing I wanted to say though, was there's an example of something I saw personally just walking on the street in my neighborhood. And it was this lady walking with her child who was in a wagon. And the child was like old enough to speak, but probably was like 3, 4, 5, enough to communicate in sentences, and old enough to communicate in sentences. And the mother was pulling the child across the street and crossing the street in the middle of the street. And there was a person walking the opposite way and I was walking in one of the directions. I don't remember which one, but the person that was passing them looked to be either homeless or, disheveled in a way that was just distraught. You would have been distraught looking at them, regardless of, who you were or what age you were. And the little girl was like greeting this person who was walking by in such a beautiful manner, like, hello, like waving and just smiling away. And the mom like completely ignored the person and just kept walking and did not even acknowledge the child's, beautiful addressing of this other individual, human being that's walking, that deserved that greeting. And I had to like stop and take a breath because I saw this interaction and I felt bad for both the person who, and the other part of the story is that the person who was all disheveled did not even notice herself or even acknowledge this beautiful comment to her. Like everybody just sort of ignored this child. And I felt so broken at that point because I saw the entire situation just as an observer. And I felt for the girl who like was trying very hard to be a wonderful human being. And the mother, whether or not she recognized it or not, just sort of went on her way. And the person who was being greeted very nicely didn't even acknowledge it, and maybe didn't even know that had happened. And I think this is such an example for today because I don't know why it popped into my mind, but it just like breaks my heart to see that. And that's what little kids notice. Little kids notice so much more than we adults do because we're so focused on what we need to do and get done and where we're going. And, we don't want to be hit by a car and all this stuff. But these children are learning at such a young age what stigma is. And the stigma is coming from everywhere. It's coming from the person being stigmatized. It's coming from the parent who otherwise loves this child, I'm sure. And, if they had seen what I had seen or had recognized what happened, like, I mean, I don't know. I feel like these situations deserve to be brought to attention because they're happening and we're just like ignoring them. And I know we can't talk about every single instance that this happens, but we have to recognize when the good does happen and when it does get missed. And I think that's I think that's the start to breaking down these barriers. So anyway, I'll stop talking.
I think that's very insightful. And back to the surgical patient, not to minimize that, but Joseph Cohn says a great opportunity for team care. But back to the child, I mean, they say through the eyes of children, right? Or how do they say that? But you know, our internal beauty is often expressed early in life, and then yeah, the person didn't notice it, so maybe the person wanted to avoid being shunned by people, so just ignores people. Sharon says we need a whole culture change. So let me give you guys a quick example. By the way, sorry, I've got gardeners somewhere here. Next week, it's Dr. Westphal, Positive Psychology, Resilience, and Well-Being, which we always love. But let me give you a quick example, and you can think for yourself, you know, what would I say? So using today's, this is not a real scenario, but using today's discussion, let's say I call you, I'm a surgeon, and I get a hold of you and I say, oh, I'm so glad to get a hold of you. I've got Mrs. Smith, who just got discharged after a hip replacement. She's over, you know, she's a user and she's over across the street in the governor's backyard. You know what I mean, right? She really needs a primary care provider because she's just doing a crappy job of taking care of herself. And she keeps using, she needs housing, she needs some transportation. So can you help her out? This user is just driving me crazy. So you don't have to give feedback now unless you want to. But think about what you would say. I mean, how in our own lives do we say, oh, so this is a woman who just had a hip replacement with a history of substance use. You know, how do we turn it around in our own mind and in our own mouth and have it come out to the surgeon? And they probably won't even pay any attention. They'll say, yeah, she's a user. I'm tired of her. She keeps coming back for drugs. But how much can we do just to kind of change the narrative ourselves? So just think about that, because it's scary. And I tell the med students this stuff too. And it's scary because I remember being on my ER rotation, and the ER doc said, oh, you don't have to go see that patient, you know, make them wait because they're just a user, you know, they say they cry sickle cell crisis all the time. So here was an African-American patient who was in pain because they had sickle cell disease, and I'm not supposed to, and I did it. I'm embarrassed. I went to somebody else first. I could have said, oh, I don't mind talking with them, but I did it. And so now I give that scenario to medical students and nursing students and say, you know, how can you feel good about yourself in that situation? What do you say back? And Renata says, ask the surgeon to rephrase what was said so there's a positivity exuding. That would scare me. But I would say, oh, so she has the issue. She's a patient who has some substance use disorder. Should I get her in to see Dr. Such and Such for that? You know, maybe just rework it. So anyway, I assume there's a severe shortage of caseworkers. Oh, always. Anyway, thank you so much. We'll see everybody next week, but wonderful presentation. And keep thinking what you'll say, because I guarantee everybody will have that situation. And, you know, you want to have something to say. And if you're willing to say, hey, let's rephrase this for the good of everybody, power to you. You know, as a medical student, I would be terrified to do that. But if you can, and Ella says, is this just to me? Nope, it's to everybody. Can she ask a favor? If there was ever someone created for this win, it's Dottie Kelly Paddock. She has devoted 13 years to Ko'olau community to make a better place to live and grow with community engagement. Oh, she wants us to vote. Okay, well, it's there. Hawaii News Now link. All right, thanks everybody. and look at all the great mahalos. But have a great week, everybody. See you next week.
Dr. Worthy, thanks, Andrew.